Okay, so a bit of a different talk for me, and thanks very much for entertaining the topic. I know that the PSU Glasgow emblem is there at the top, but this is just because that's where I work. It's not a reflection of anything that ever happened in Glasgow, but this is Evelyn's story. I am her dad, and as you can see, she is full of character. So the disclaimer to this talk is that she was never actually that sick, right? So, and I thought a little bit about whether I should even take the time to share my experiences being on the other side of a child in ICU, because she wasn't that sick, certainly in terms of where my benchmark is. But I still think there was lots of learning opportunities from my experience, and therefore I still think there's value in exploring that. But Evelyn began her journey quite a while ago. She is a surrogate baby, so she began her journey in 2022. And as all surrogate babies are, she was an IVF embryo creation, which is a bit different to what is the norm. And I'll use that word a couple of times potentially, but it's just recognizing that things were a little bit different for her. She was a surrogate baby born in Colombia for lots of different reasons. So she is currently Colombian, and as of yesterday has a UK passport and is also a UK citizen. And it took a long time for Evelyn to make an appearance. We had a lot of embryo transfers across 2024 that were unsuccessful. And so she was long awaited and loved before she arrived. The antenatal story was, let's see if I can minimize this actually a little bit, because this is probably on your screen as well. I don't know if it is. There we go. The antenatal story was unremarkable, or so they said. And what I mean by that is in the surrogacy program, we get regular monthly updates. And we were told as we asked and as we communicated with the surrogate and with the clinic that everything was fine. And we arrived in Bogota at about 36 weeks gestation, planned to be there early just in case Evelyn made an early appearance. And part of that was us being able to go to the clinic appointments with our surrogate, and also anaesthetic appointments, planning appointments. And it was during the anaesthetic appointment, recognizing that all conversations were happening in Spanish, and Google Translate cannot keep up with conversational Spanish. What I did recognize were words such as metformin. And that just sent a little bit of alarm bells in terms of, okay, there's clearly gestational diabetes going on. Why didn't I know that? You know, I have asked, is everything fine? And I'm told everything's fine. So that was a little bit frustrating, and also made me question, is there anything else that's gone on that I don't know about? We went to a clinic appointment at 37+5, and whilst the surrogate was in at the appointment, normally she would go in first and then we would go in after to join her. She texted me and said, they're talking about my blood pressure being high. They want to send me from the clinic to the hospital. And then she said, oh, I think there's protein issue. And I said, right, this is going to be preeclampsia. So she came out with a letter and she said, yes, they want me to go to the hospital. Shall we go and get breakfast on the way? And I said, I don't think that's a good idea. I suspect you're going to get a section today. Let's arrive fasting and then see what happens. And I'm glad we did, because lo and behold, there was a plan for an emergency section. Evelyn was born in good condition. She spent 48 hours in neonatal ICU, not because she was in any way unwell, but because our surrogate was admitted to adult ICU for blood pressure monitoring, as that was their routine practice. She was fit and well, but she was there for monitoring. The practice in Colombia is that when a baby is leaving the hospital, the surrogate or the gestational carrier or the birth mum, depending who it is the person who carries the baby over the threshold. So from a surrogacy point of view, that means the surrogate carries the baby over the threshold and then hands the baby to you. But a very kind neonatologist on day 2 came to us and said, why on earth are you still here? Is that the only reason you're still in this hospital? That's ridiculous. Went and got a disclaimer signed, and we were able to leave and go home. So obviously it wasn't home, it was in Colombia. It was in an Airbnb. But we settled into family life, getting used to the feeding, the routine, the sleepless nights, the baths, all of those normal things, and everything was really, really lovely and as good as we expected it to be. I will say that the first bath was fairly traumatic for her, and now subsequently she loves the bath, but she was small. She was 2.7 kilos when she was born, and over the course of the first week dropped down to 2.5 kilos. So within the expected realms of weight loss, and she was doing well. Seen by a paediatrician routinely as part of our surrogacy plan at a week of age, and everybody was happy with how she progressed. However, shortly after that, she wasn't great. And you will sometimes see people or hear people talking about a baby that's unwell that just looks at you with sad eyes. And I know that's not scientific, and people might be like, oh, that's nonsense. But sometimes when you're doing a ward round, you look at a kid and they're just looking at you in a way that you're like, I feel like you're asking me for some sort of help in some way. And that is very soft, but it is genuinely something that I think is real. And she was looking at me like that. And then if your volume's up high and you can see this video, you'll see what she was like. So I don't know if that's easy to appreciate, but she is at rest, sleeping, settled, but she is grunting, and she has got work of breathing in the form of a kale plug. She's got interconference lower section. So of course, being the first time dad, I'm like, oh my word, I need to bring her to hospital. But am I being ridiculous? I'm an intensivist. I'm immediately thinking this is crazy. I know the red flags in terms of work of breathing, but somebody else tell me I'm doing the right thing. Luckily, I know a lot of pediatricians, sent them the video and said, I think she's grunting. I'm going to bring her to hospital. And they said, of course she's grunting, bring her to hospital. And that is good for me personally, to have somebody that can ground me and be like, you're not being ridiculous. But she displayed work of breathing. So we brought her up to the hospital in which she was born. They checked her saturations with an adult saturation probe, which was surprising, but the saturations in her were about 88%. And therefore we were told we were being admitted, and their policy was to admit to neonatal intensive care. So we were in a holding area for quite a while. She was relatively comfortable. Numbers were okay. Heart rate was in the sort of 140s to 150s, and saturations were easily maintained in the mid to high 90s on a very, very small amount of oxygen. So pretty okay with that. She was brought up to the ICU, and we were asked to sort of leave until they got bedded in and all the rest of it. And she was electively put into a cubicle and then electively stripped down and put into an incubator, which obviously was turned up from a temperature point of view to maintain her temperature, even though she was stripped, and she was kept on her nasal cannula oxygen. And from there was a number of disagreements and things that I personally struggled with. My concerns were feeding, the use of medications, and skin breakdown. And the biggest one for me was her feeding. Now, from a feeding perspective, before she went into hospital, she was on 150 mils per kilo per day. So she was on full feed volumes, what you would expect a baby to be tolerating. And she was putting on weight again after dropping to 2.5 kilos. So we were happy she was going the right direction. She was tolerating 150 mils per kilo, and that equated to 60 mils 3 hourly of feeds. And whenever I had a history taken at the start, I was very clear on that. And then I heard them say to the team, she feeds 60 to 90 mils per feed. And I said, no, she feeds 60. And she's got bronchiolitis. She's RSV positive bronchiolitis. So therefore, she could probably be okay with about 45 mils of feed as long as she maintains her blood sugars. 45 is fine. Despite that, they kept trying to push her to take 90 mils of feed. And they pushed and pushed up to the point where they were almost aiming for 300 mils per kilo per day. And that concerned me. And every day I had a conversation with them and explained what my concerns were and asked them, could we just agree at least no more than 60? Every morning they agreed. And every night shift when I was around and they had to change of staff, they went back to trying to give her 90 mils. And what really upset me was whenever I was feeding her, or when I was allowed to feed her, and I gave her a bottle and she took 60 mils, they would shake their head and tisk at me for not giving her 90, even though I said I was happy with the 60, as if I was doing a bad job. And that was really hard. And that was really, really frustrating, because you felt you were being told you weren't doing a good enough job. And lo and behold, then they pushed, and I came in after leaving for a couple of hours, swapping, doing shift work, came back in to find that an orogastric tube had been put in and they were tube feeding her, again, pushing to get these volumes. And what frustrated me even more was that, as you can see from the picture on the left, they used gravity to tube feed. And quite often they would put the milk into the syringe, walk away, and the milk would just sit in the syringe. It didn't actually go anywhere. So she wasn't being fed. And at times she was crying and upset because she was hungry. And the one positive out of that is that one nurse came in and she just put a slight angle where the feeding syringe met the incubator, almost putting a kink into the actual NG tube or the orogastric tube itself. And that made the milk flow in quite nicely, which was a trick I didn't know. But if you're going to think about silver linings of this experience, that was very useful. And then over the coming days, anytime she was fed and people would walk away leaving this milk in a syringe, I knew how to make sure that the milk ran in. Now, on one occasion, they insisted again on night shift to try and give her 90 plus mils, and she vomited. And then she vomited and she started working hard because she had just vomited. The medical team was asked to come in, who attended immediately, and told me that she needed salbutamol. I said she didn't need salbutamol. Her heart rate was 185 to 190, and that she was working hard because she just vomited. And actually, leave her alone. Or if you're worried about aspiration, then get her a chest X-ray and see what we're dealing with here. And you can have your own views on that, but I certainly felt salbutamol was the wrong thing to do. And they weren't happy that I declined the use of salbutamol, but I felt strongly about it, that it wasn't necessary and it was wrong. And then the third thing was skin breakdown. Her skin was fine when we entered the hospital, and during the course of the admission, for whatever reason, and I don't know why, her skin breakdown around her nappy area was really quite significant, one of the worst I've seen. And it resolved whenever we got her home. There is no blame attributed there because I don't think anyone did anything wrong. It was just an observation and another element that I found stressful. It was hard being separated from her in terms of being able to hold her, being able to form a connection, recognizing that surrogate is in a different country, trying to form a bond and an attachment. She hasn't heard our voices antenatally, that's for sure. It was really difficult to then be separated from her and to watch her struggling. And on occasion, 2 occasions over the course of a number of days, one of the staff very kindly let me hold her. And that was really important for attachment and for just having that human connection. And we greatly appreciated that. So my issues were, and I sat on one of the last days, towards the last day of our admission, and I finally, after requesting many times to speak to the medical team, one stuck their head in the sort of isolation room and said, thumbs up, and closed the door and walked away. And I had to come back, run out and be like, come back here. I've been waiting for days to speak to somebody. And I said, listen, from my point of view, the oxygen, she needs it. Yeah, her sats absolutely drop when we try and take it down. Not very much, but she definitely needs some. The incubator, I don't think she needs it, but I'm not arguing about it. It's fine. Don't mind. Do you know, if you think that's your policy or that's the right thing, don't mind. Feeding volumes, I feel strongly about that. It's not necessary and it's made things worse. There are things that you might want to do that I don't mind. I don't necessarily think they're required, but I don't mind. But if you're going to do something that I think might cause harm, then I do feel strongly about that. And therefore, that is why I keep raising this concern about feeding volumes. And it has made her worse. The tube feeds were probably not needed. Salbutamol is absolutely not needed. And it was very clear in that conversation that their priority was optimizing calories and growth. And it was very much, in my opinion, this is bronchiolitis, this is a pediatric ICU bread and butter, this is my bread and butter, what I deal with all the time, versus their mentality of this is a neonate who needs to feed and grow. And she didn't need to feed and grow, she just needed to have the support that she required, but without over-egging it. And therefore I felt she was over-medicalized. So we agreed that there would be no new changes made without discussion and conversation. And I think we were respectful and towards each other, recognizing that we did have different opinions on things, but we were both trying to do the same thing. And my frustration was that I never wanted to be Avine's doctor. My role was her dad, and that was it. And I wanted to have that role and just have that role. I felt really frustrated that I felt the need to advocate so strongly from a medical perspective, and I found that really upsetting. That's not what I had wanted for my relationship with the team. And then on one morning, we got a knock on our Airbnb door, and it was an insurance company with oxygen cylinders who told us, "Oh, by the way, the hospital, have they told you your baby's getting discharged today?" No, nobody had told us that. So we had no idea she was coming home. And we obviously rocked up to the hospital, and they said, "Yeah, you're going home. No medical discussion. Um, Bring her home and arrange your own follow-up," which we thought strange, very strange. So we brought her home. We did have an outlet in terms of a home monitoring system, which, I mean, I'm a big advocate of, particularly now, but for a number of reasons, I'm a big advocate of that. It works for me, and she still wears it every nap and every nighttime. And we contacted the pediatrician who had done her 1 week check. She agreed to see her in a couple of days' time. I started weaning her oxygen, accepting saturations on average of 92 and above. It did stimulate me to go and look at the literature. There is some really nice bronchiolitis literature in high altitude countries based out of Bogota and Colombia. So that was useful for me. And then lo and behold, we got a message from the surrogacy clinic to say that a pediatrician had been arranged and was coming out the next day. So within 24 hours, we had 2 pediatrician appointments. Both of them knew each other. And that was a bit unusual, but it was just not what we had been told we needed. Life with home oxygen is fairly restrictive, and big cylinders, in terms of even just moving around to do nappy changes and baths and whatnot, it is quite difficult. But we were lucky actually to be in a relatively small B&B, so the mobility was less of an issue. She did well, and we weaned the oxygen off fairly quickly, I would say. And 2 days after that, we arranged to get her flown home. Getting home was challenging. It had its own issues not from a medical point of view, but from a certificate of an entitlement, which is different from a visa, but the same concept. But it was important for us to get her home and finally have family support and get her settled into her actual home. As you can see now, she is absolutely thriving. She is piling on the weight. She now loves her bath, and she is a very, very happy little girl who's had her own issues in terms of feed intolerances, cow's milk protein intolerance, whatever. But she is absolutely thriving, and she has jumped up to somewhere between the 75th and 91st centile. So what are my reflections from this experience? Firstly, I found it really difficult to even write this presentation, and I didn't expect to. But reliving those challenging conversations and that constant need to advocate and feel like you're fighting every day on something as simple as feed volumes was really quite difficult. Language barrier was difficult. We were never offered an interpreter or translator or whatever. We were using our phones, and that was hard. The medical team weren't particularly present for us, despite us asking to meet with them, and that was hard as well because we did ask. And I did feel like I didn't want to tell people how to do their job or assume that I knew best, but I couldn't be afraid to advocate for what I thought was right. And the conversations that I had, they did stimulate me to challenge my own thought processes. Is there a role for salbutamol? Historically, a lot of us have been taught babies don't have the appropriate receptors. Well, actually, the more recent evidence says that they do. It's just that they don't work in bronchiolitis because of the pathophysiology. So obviously, I wanted to separate the roles of being an intensivist and being a dad, but I wasn't able to. And the loss of control over how my daughter was managed was really difficult. Challenging dogma I've mentioned, I think that was a really good thing for me, personally, professionally, making myself challenge myself in terms of what's the right thing to do. There were positives, learning little tricks for orogastric tubes. The team were trying their best, and they did have Avine's best interests at heart. The community pediatrician who had performed her 1 week check, we did contact her through the process and tell her what our concerns were. And she phoned the neonatal unit and she advocated for us. And she said, I've spoke to so-and-so, they're on tomorrow, they're going to come and speak to you. She tried her best, and having her as a point of contact was really useful, and we felt incredibly supported by her. And we're very grateful for that. And we're very grateful for the care in general that was provided. So that is my experience of AVing. We are going back for round 2. Baby boy is due in January, so we are going back to Bogota very, very soon. And yeah, if you have any questions about that, please do not hesitate to ask. And I'll finish there.